I've been doing this work a long time. Sorry. And I have a great deal of gratitude for being able to do it with the folks who are in the room tonight. I need to open up by thanking the Conti family, Wendy and Marie, for helping make this possible. I want to thank Ken in the back. This is this room and a lot of the food that we're having is donated tonight by Ken. He's got a business to run, and but he's letting us be here tonight. So people need a hotel stay at the Hilton Garden Inn. I want to thank Buck and his family, Buck's been traveling doing a lot of these videos so that folks can hear these stories. And none of these folks that you see before you or who helped make this possible, in terms of the Conti family, Christine Emerson and her family, they don't get paid to do this. I do. This is my job. I'm blessed to have it. But none of these folks get paid to do this. And my job is to work with these folks and to help facilitate a process where we can achieve a shared goal. And our shared goal here is getting New York to pass a comprehensive medical marijuana law. I get to work with Julie, my colleague Julie Netherland over there, and a great team of people. We get to work on this effort. So Compassionate Care New York, which sponsored this tonight, along with a range of organizations that are in your program here. It's comprised of thousands of patients and families from across the state, roughly 70 organizations that have endorsed this, 650 doctors that make up Physicians for Compassionate Care that Dr. Lacombe is a member of. New Yorkers across the state are a part of this. And there's a flyer up there somewhere that lays out a range of activities that are happening this month. We're calling it the March of Compassion. So this forum is happening here, but there's forums happening in the next couple of weeks in the Albany region, in Mineola, Long Island, in the Westchester, in Albany, in Brooklyn, in Syracuse. And all of that is happening in conjunction with lobby days in Albany. Why is all of this necessary? Well, that should be evident at this point here in the stories. It should be quite clear. New York has a medical marijuana proposal right now under consideration in Albany. We had a PowerPoint to show you about what this stuff is, and it's not working, so I'm just going to walk you through it. But I want folks to know that there's a fact sheet in the back, a frequently asked questions in the back that will walk through a lot of this stuff, as well as a lot of other information that we can provide you, and copies of the bill. If people want to read the actual legislation, we have that here, and you can get it from Julie Netherland when we're done. Let me give a brief summary of medical marijuana in the United States so that folks understand what is taking place in Albany. There are right now 20 states in the U.S. that have medical marijuana laws, 20, plus the District of D.C. Nearly a dozen other states, a little more, are currently considering passing these kinds of laws. And that includes everything from Florida out to Alaska. Alaska has that law. I mean, it's all over the place. New York first proposed a medical marijuana law in 1997. It's been in the legislature every single year since that time. 1997, 98, 99, 2000, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, and now here we are, 2014, and we're still in Albany trying to get this bill done. It's not because the human need isn't evident. That's clear enough by being here tonight. That's not why the bill's not been done. It's not because the proposal has not been crafted with care. You're welcome to read it for yourself. Let me walk through a couple of things of what this law would do. It would create a tightly controlled system for patients to access medical marijuana under the supervision of their healthcare provider. It would create a system to produce that marijuana that would be under the control of the State Department of Health. And it would make marijuana the most tightly controlled substance in the state of New York. Think about this for one moment. It would make marijuana more tightly controlled and regulated than OxyContin, than oxycodone, certainly more so than tobacco or alcohol, and far more so than many of the psychotropic medicines that get locked up in pharmacies in safes and so forth. It would make it even more controlled than that. Remember what Dr. Lukhomy said, that there's no evidence of an overdose ever occurring with marijuana. That doesn't make marijuana safe. It is certainly safer than many other medications, but has been noted here there's a risk to nearly everything. But the balance here is that the benefits to be found by enacting a program to access medical marijuana so that a patient and their physician, their healthcare provider, can make a determination as to whether or not marijuana would work for them is essential. Some people, like the Williams family and the Conti family and the Emerson family, have children who need to have access to strains of marijuana that are then turned into oils and tinctures so that they can consume it orally as a food. Some, like the MS patients and the cousin of Reverend Pierce, need to be able to smoke it because it's the only thing that stimulates their appetite so that they can eat. There's a number of different ways to ingest it. And how one ingests marijuana for medical use really should be up to the determination of the patient and their physician. That's where that discussion should take place. When I get sick, I promise you, I do not call my state senator. They usually don't. If one looks at the Compassionate Care Act, you would find that of the 20 states that currently have medical marijuana laws, including every state in the Northeast except New York and Pennsylvania. Consider this. If you go across to Vermont, you can get medical marijuana if you're a patient. New Hampshire, Maine, go over to Rhode Island, Connecticut, Massachusetts, go down to DC, Delaware. You can get medical marijuana in all of those places. I live in Brooklyn, New York. I go to work in Manhattan, and when I look across the Hudson to New Jersey, I see a state where patients can access marijuana. We work with a doctor who works in New Jersey. He's one of the co-directors of Physicians for Compassionate Care. He has a practice in New York and a practice in New Jersey. And he says, what in the world is going on that I can provide my patients in New Jersey I have this tool in my toolbox in New Jersey, but I don't have it in New York. If you looked at the Compassionate Care Act and you compared it to those other states, you would find that the proposal for New York would make the program here amongst the strictest in the nation. It would be the most tightly regulated and controlled. It would arguably be one of, if not the best, such proposals in the nation, because it would allow for patients who need the marijuana to access it. It would allow doctors to make that recommendation, and it would be, as I mentioned, tightly controlled by the state. Because 20 other states have moved forward with this, we have a lot that we've been able to learn as to what works and what doesn't work. And so it gives us a chance to look at those other states and say, nobody wants anything that looks like what we see on TV with California. That's clear. I think we'd all agree to that. We also don't want to end up in a situation like Maryland that passed a law that's strikingly similar to the one that Governor Cuomo has put forward. You may have heard that Governor Cuomo had his own proposal. And we were very pleased that the governor finally came out and said, I recognize the medical value of marijuana for certain conditions. That was quite good, and we applauded the governor for that. But he put forward a proposal that would look a lot like what they did in Maryland. And in Maryland, we don't count that state as a medical marijuana state because there aren't any patients accessing medical marijuana in that state. Or there's very, very few who ever will. I'm going to read a couple of things briefly here because there's been some talk about the science of medical marijuana, and certainly Dr. Lukhomy can speak to the medical science of this certainly better than I can, but I'm going to read a couple of things here because this gets to the point that I'm going to make, which is why is it that we're even having to be here? Why do we even need to have a forum like this in the first place, given that that certainly the stories are quite compelling? There's not a challenge in creating a system that will work, because 20 other states did that. I mean, interestingly, if you go north to Canada, they have a federal medical marijuana program. They've done it as a nation. So has Israel. Right? So we could go right across the water to Toronto and meet with patients who have a program there. So we know that it can be done. So then what is it that's the holdup? Well, the thing that we hear a lot in Albany is, well, there's not enough research on this. There's opposition. There are people that are opposed. We know that this might be a hard thing for some people to work through. Quote, evidence not only supports the use of medical marijuana in certain conditions, but also suggests numerous indications for cannabinoids. Cannabinoids are one of the, there's a range of different cannabinoids. CBD, the oil that I think Ms. Williams referenced that would be helpful potentially for Tommy or for Anna or for Julie. That's a component of marijuana, one of the cannabinoids, but there's a lot of these different cannabinoids. I'll read this again. Evidence not only supports the use of medical marijuana in certain conditions, but also suggests numerous indications for cannabinoids. Additional research surely is needed to further clarify the therapeutic value of cannabinoids and determine optimal routes of administration. The science of medical marijuana should not be obscured or hindered by the debates surrounding the legalization of marijuana for general use. That's from the American College of Physicians. The evidence demonstrates a connection between therapeutic use of marijuana and symptom relief. That's from the American Nurses Association. When appropriately prescribed and monitored, marijuana cannabis can provide immeasurable benefits for the health and well-being of our patients. We support state and federal legislation not only to remove criminal penalties associated with medical marijuana, but to further exclude marijuana cannabis from a classification as a Schedule I drug. A Schedule I, that is from, I should note, the American Academy of HIV Medicine. The federal government has scheduled marijuana as a Schedule I drug, which means that they say there's no therapeutic value to this. There's no medical value. The only reason that states have to pass laws like this is because this issue has become so politicized that in Congress, I'm sure you all have heard of the war on drugs or the drug war. So in Congress, right, that's part of what's been going on a long time. And they have said there's no medical value to marijuana, and they've made it a Schedule I drug in the classification system that they use. And that system is important because where they schedule a drug determines whether or not doctors are able to get to write a prescription for it and pharmacies are able to distribute it, and then how that's going to happen. Right? So when you go to the pharmacy to buy your aspirin, right, it's because it's a Schedule III or Schedule IV. What is it, Julie? It's of a higher schedule, means that they can do it over the counter. But if you want, say, your OxyContin, that's a Schedule II drug. You know what else is a Schedule II drug? Cocaine. It's not a Schedule II drug, it's Schedule I. But what the federal government is saying is that there's no medical benefit to marijuana. But I want to share something with you. The evidence in this record, I'll read this. The evidence in this record clearly shows that marijuana has been accepted as capable of relieving the distress of great numbers of very ill people, and doing so with safety under medical supervision. It would be unreasonable, arbitrary, and capricious for the DEA, the Drug Enforcement Agency, which is responsible for this scheduling, to continue to stand between those sufferers and the benefits of this substance in light of the evidence in this record. The record here establishes conclusively that at least a respectable minority of physicians has accepted marijuana as having a medical use and treatment in the United States. That the other physicians may not. Some doctor. Where am I at here? I'm sorry. Let me read this again. The record here establishes conclusively that at least a respectable minority of physicians have accepted marijuana as having medical use treatment in the United States. This is from a guy named Francis Young, who was the Drug Enforcement Agency judge who did this ruling in 1988. When he was telling the DEA, hey, you shouldn't be scheduling this as a Schedule I drug. And at that time, you didn't have even as many of these different groups of physicians like the American College of Family Physicians and so forth that have come out in support. Right? More have come out in support since 1988. The DEA ignored this ruling. The only reason that we're having to pass a state law in the first place is because Congress won't act. Maybe that's the shortest way to say it. Now imagine, if you will, for a minute, if what we had to do was to wait for Congress to do something in order to help the Conti family, the Emerson family, Reverend Pierce's family, folks living with breast cancer. The folks down in D.C. can't get themselves out of a paper bag right now, let alone change something that they did a long time ago around something like marijuana. Which is why states have had to move forward and say, since Congress won't act, we as a state are not going to wait around and let our patients suffer. And the first state to do that was California in '96 with the voter referendum. And then you had Washington and Oregon and Arizona and Alaska with voter referendums, that we don't have that option here. But then you had states passing this thing through state legislatures like we have here, Connecticut, Vermont, and others. This is our binder that we take, and if any of y'all want to look at this, we have a few to spare, and I encourage you to look through it because it's got the science in here, it's got a lot of the research, the history of this stuff. I'm going to wrap this up by saying the only reason this has not passed is because the folks in Albany have been derelict in their duty to serve the people of New York. They're not reading the science. They're just saying things out the side of their mouth without knowing what it is that they're talking about, and they get away with it, largely because they're Senator such and such or Assembly person so and so. Now there's a lot of good people in Albany, and I don't want to be mistaken as saying anything otherwise. But we have people suffering right now in this state, and a proposal that will work. We know it can work, and we know the value that it can do. We have doctors asking for it. We have families that need it. When you look at the polling, if that was the only concern here, then we should be somewhat lifted, because when the last poll showed that nearly 90% of New Yorkers supported this, including supermajorities of Democrats and Republicans. It's not a partisan issue. Whether you look upstate, like Western New York like we are here, or the Adirondack region, or the Mid-Hudson Valley, or the Southern Tier, or the Westchester area, or New York City, or Long Island, there's not a region in this state that doesn't support allowing patients to access medical marijuana under the supervision of their healthcare provider. The only folks who are confused about this are the ones that we've been sending to Albany. Which may say something about us too, just to be fair. We're going to open this up to Q&A, but we're two things before we do this. You all came out tonight for whatever the reason. You have questions, you're going to be able to ask them. You have concerns, you want to support this stuff. You have feelings with it. You're not quite sure this is right. You have concerns. That's all good. As Marie said, we're going to have a respectful dialogue with each other. For those of you who think that what we're doing here is wrong, that what we're doing by not allowing patients to access this thing is wrong, that what Albany should do is take action, we're going to get to the action steps before y'all leave. There's some stuff in the back that I'd encourage you to grab before you go if you got to leave before we wrap up here at 8:30, because Ken needs the room closed out by 9. We told him we would do that. But we're going to have a lot of time to dialogue with each other, and at the end, Wendy's going to talk to us about some of the action steps that we can take, because there's very little things that we can all do, and I'll say this very briefly. We've been working on this issue a long time, and when we started this new campaign around this, try to reinvigorate it, because like I said, it had been going on since 1997, and a couple of years ago we said we got to do something differently here, and we started from scratch. And last year we got this thing through the state assembly, and folks told us, oh, you'll never get that through the Senate, and the governor's opposed to it. Nothing's ever going to happen. And all the smart folks in Albany that get paid a whole lot of money to be a lot smarter than I am about what's going on in that beautiful building, our Capitol, said the governor's never going to do it, you're never going to get this stuff done, whatever. Fortunately, I am a stubborn mule, and the folks that we work with are stubborn. We don't take no for an answer. And so at the beginning of this year, the governor turned around and said, all right, I'm going to support this thing. And he put forward something we think he should have done a little bit more on, but at least he started with a good foot forward. That didn't happen because he just woke up one day and had an epiphany, although he may have. That happened because a lot of the folks you see here in front of you, and a lot of the folks around this state, did little things that added up. Small drops of water fill the glass. They called every single day. They sent mail in. They clicked here and sent that email. They joined. We have these monthly conference calls that we'd invite you all to join, where folks from around the state get on those calls, right? They came to Albany. They met with their local legislator. They got their churches involved. They got local folks involved. So we're not the ones with a whole lot of money being able to move and shake up in that place like some other folks can. That's not who we are. We're folks that if we're going to get something done like this, we can only do it together. That's the only way it's going to happen. Small things make a big difference. The only reason why we now have four, count them, 4 Senate Republicans from this region, Senator Maziarz, Grisanti, Roebuck, and, well, Gallivan's not quite there, but O'Mara, but he's starting to come out. Kennedy too. The only reason that that's happening, and bless all of them for coming out, the only reason that's happening is because they're hearing from these families all the time and these patients. They're hearing from folks like Reverend Pierce and Dr. Lacombe. They're hearing from folks every single day. Is all building as an advocacy movement and making sure that they understand that we're not going to let them go back and forth between Albany and then back home without coming back saying that they've done something to improve people's lives. And so we believe that we are close to being able to pass the Compassionate Care Act, closer than ever before. The Assembly, for the first time, included the proposal in their budget. Right? So where we are right now in the Capitol is that the governor's put forward the state budget and he says, here's my proposal, and now the Assembly and the Senate have to put forward their proposals, and then they all got to get together and work it out until they come up with an agreement. Right? For the first time, the Assembly said, all right, we're going to include this in the budget, in our proposal. We're going to do that because it creates a new system. There's going to be rules and regulations. Money will be generated, fees, taxes, and so forth. So it makes sense to have it as a budget element. That doesn't mean we're done. We're not over the finish line, but we're farther than we've ever been. We got new Republican support when the Republican conference has been the one saying for a long time, we're never going to do this, even though privately, many of these senators say, oh, we're with you, but we can't say it in public. We heard this. And so we're going to get to the Q&A. So we build a momentum. The budget is due April 1. Keep this in mind. The budget is due April 1. So we have an opportunity to get this thing done by April 1. But we got to all lay hands on it and push it. It's the only way it's going to work. Because remember, a lot of the folks that are there in Albany, some of them want to do good, but what they need is a good kick in the rump to do it. And we have to provide that. So I want to thank the Hilton again for hosting. I want to thank Marie for facilitating. We're going to do some Q&A now. Thank you all so much for coming out.